10 years ago, when we started this program, all my colleagues were saying, what are you thinking about? There's all these programs in Philadelphia and all these programs in Baltimore. You'll never make it in Delaware. And what I found out 10 years later and 250 kidney transplants later is the fact that people in Delaware want to stay in Delaware. And so what we have to do is provide them the best care possible, right? And so with that trust comes this great burden. And so I personally want to thank Claudine for trying to organize us all, and to answer your question, as one voice talking for each patient. And we can do this in Delaware because we're uniquely small but powerful. Anyway, and I'm a convert. I'm from the Midwest originally. So anyway, I'm going to talk a little bit about chronic kidney disease, end-stage renal disease, and of course my love, transplantation. I work at the end, but I wish that that didn't have so much business. I wish that we had people recognize, because this is a big problem in our state, but it's a silent problem, I think, is the idea of chronic kidney disease. So just to rehash a little bit, these are the stage 1 levels. Creatinine clearance is the actual measure. Your creatinine can be one thing, but it's based on your age, race, gender. So all these things are impactful, but where I think we get the most bang for the buck is finding out who's stage 2 and really has situations early. But stage 3 and stage A, B, and B can be where we can actually get influence. Hopefully to arrest progression, keep people at some level. Stage 4 and stage 5 is where I get involved. So anyway, again, like we were saying, it's hard to get the actual data for CKD, but this is from the Delaware Health Tracker, from the Delaware Hospital Association. And you can see from our standpoint that in our Medicare population, we've had this accelerating percentage of patients with chronic kidney disease. I'm not going to give you stage here or whatever and what the combination is, but you can see we're greater than the national average, and we're bordering on the red, okay? If you look at our counties, and I think this, particularly in our state, with 3 counties, with a urban, suburban, and a rural feel for each one, we have a unique way of studying population. So I think this, again, our program is great. But from the standpoint, those are the kind of things where we're seeing our most influence. And again, more the urban population having the higher degree of chronic kidney disease. So this is the idea of the Medicare data again. So 65 plus, you can see it's 17.5, so even a greater number. But even under 65, we still have what's higher than what's sort of been quoted today of this 1 in 10. We're at about 15% of our population with chronic kidney disease. Tends to be more of a male disorder, and that reflects with more patients getting transplanted as well. Here I think we're talking about tonight, some already have been addressed with the idea of diversity and issues of, for our African American population particularly, you can see that this is a higher percentage. In an area where we can certainly do a much better situation. I must admit I'm tired of seeing patients who are young African American males particularly coming to me with a history of hypertension only, and if we could have intervened early, we wouldn't have to do their transplant. The other thing I want to point out is that we're from the idea of us being having this higher incidence end-stage renal disease, but from our standpoint of associated conditions, particularly with diabetes mellitus, look at where we are in that scale down the bottom. We're in the red. We're considerably higher than the national average, and again, diabetes is a third to half of my list. So again, if we can work early and hopefully control diabetes, we can improve the downstream, as Dr. Heaney has mentioned. And again, hypertension, we did a little bit better. We're down to this situation, but again, we're still in the red relative to hypertension. National average 55, we're at 61.8%. And again, in our situation where we have, particularly with our African Americans, this can be a real problem because they have hypertensive nephrosclerosis. Now again, it was hard to get this data, and we have, I was talking to Dr. Lindsay Slater. I would consider the Nephrology Associates as a proxy because of their size for CKD data in our state. And as far as it looks right now, stage 1, 4, and 5 in their database shows about 1,000 patients with stage in Newcastle County alone. Lower Delaware, about 600. The stage 3 data she thought was difficult to obtain, to sort out, so she wasn't going to let me use it, but I know she's already confirmed with Claudine, and I think the number they gave me is probably pretty close, but probably greater than 10,000 people in their database are considered to have stage 3 disease. Don't hold her to that. And stage renal disease. So now, unfortunately, we have too many people progressing. And if you can see, again, from the incidence and prevalence, you can remember Dr. Henian's definitions. These are the 2014 data. And we had about 360 patients, new patients. But again, I want to focus on the blue line, which is diabetes mellitus, which was about a third, and hypertension. Those two together produce more than half of our prevalence of kidney disease in our patients. And then the prevalence is certainly high, again, with diabetes and hypertension providing the greatest numbers. When I say those others, and particularly in the situation with the prevalence, that's 50 different diagnoses as opposed to these 3. And then age, as mentioned, as we have this aging population, the older we get, the more risk we have for issues, and indeed it fits with chronic kidney disease as we move that scope more and more to the right. Older age, greater evidence of kidney disease. Again, this is an idea of what we've talked about in diversity and getting the word out to our minority patients that this is the incidence and prevalence are going to be high in our African American population particularly. You can see our incidence was a little bit different, but the prevalence is key, and we need to get those patients recognized early and treated early. When we talk about renal replacement therapy, I of course put transplantation at the top, hemodialysis and peritoneal dialysis. That's not the way to really look at it though. These are all on a spectrum of treatment. Transplantation is not for everyone, hemo is not for everyone, peritoneal is not for everyone. You have to pick each person's correct therapy. But you see I put the arrows directing back and forth. Now I'm hoping as a transplant surgeon that the arrows don't go back at all and we can have 10, 15, 20 years of survival, but I know that's not the case in all patients. So it's kind of a continuum of what our patients go through on a regular basis with their end-stage renal disease, transplantation to hemo. Maybe they want to try peritoneal, maybe it doesn't work. You go back to hemo, you go up to transplantation afterwards. So these are the kind of things that we are constantly looking at. So what was the state of dialysis in Delaware in 2014? Home therapies, actually this is a comparison to 2013 data. There was an increase in home therapies, more and more patients doing peritoneal dialysis at home particularly. I know there's more, I'm hearing more and more of my patients coming in doing home hemo as well. 2014, 1,400 Delawareans on in-unit dialysis. You can see the increase there from 2013. And I know these numbers are beyond. I know we're accelerating and there's more today. And then my love, of course, transplantation. We have 2 units, 2 centers in Delaware. We've absolutely divided this based on age. 21 or less is A.I. DuPont Children's Hospital. Some of these patients do transition to us because of the long waiting times, and they come to us and we see them as when they're 21 and they come to our list. But we go age 21 to age 75. When a person gets listed, just so you know the vernacular, it's the United Network for Organ Sharing. It's based on in Richmond, Virginia. It's the organization, it's the umbrella organization that is responsible for just and properly utilized organ allocation in the United States. That's where people are listed, if you will. Gift of Life, as you probably have heard about, is our local organ procurement organization, and is for our region. And our region, or our area, includes all of eastern Pennsylvania, southern New Jersey, and all of Delaware. And that is our local list, if you will. 15 transplanted centers, 12 adult, 3 pediatric. I had to throw this in because everybody wants to see surgery. This is where we actually do this. So people always think, well, where does the kidney go? It goes in the belly. But our problem is the donor shortage. So if you're a blood type A, you have a 3 to 5 year waiting period. Blood type B and O, it's 5+ years. Blood type AB is variable, of course, but they can also receive A organs. So they may be, they could have a short or long waiting time depending on the situation. But it's a long waiting time for everyone. And so we have to bridge that gap. That's why it's very important that me as a surgeon, even though why as a surgeon giving this talk, is because half my practice is medicine. And my working with nephrologists very directly to try to make sure that the patient that I list today, 5 years later, is the patient I can still transplant safely. One of the things that we've really worked on is to promote living donation. Well, you can say, well, gee, why not just give everyone a living donor? Unfortunately, you want one recipient and one donor, not two recipients. So not everyone can have a living donor. In this country, it's about a third of patients will benefit or will be able to get a living donor. One of the things we've done to expand our reach is we've participated in a paired donor network where a kidney that we recover in Delaware may go to Texas, a kidney that's recovered as a living donor in Texas may go to California, and circle the whole system until our patient gets their kidney back. We've done about 5 or 6 of those with great success. In fact, we were part of that 32-person chain that you may have all seen on ABC News. We were about in the middle of that chain, the longest in history. And with this, we can offer waiting times less than 1 year, or whatever it takes to get patients transplanted. One thing for our situation, when we're in an urban population like ours, it's due to familial tendencies of renal disease. It's hard for us to always find donors that are possible. So one of our differences between us and dialysis is that we can intervene prior to end-stage renal disease. And so again, it's important that we work with our nephrologists very closely, because anybody with a creatinine clearance of 20 or less, so stage 4, not even stage 5, or not, it doesn't have to be end stage, we can actively list that patient or even transplant them. And if you look at the overall data, there's a survival advantage for being transplanted preemptive to dialysis. So if this can happen, we want to see patients as soon as we can so that we can get them listed as quickly as possible. And this is just kind of a list for the nephrologists can see this, but there's some times where you see significant benefit. And the reason this is important now is that dialysis time has become the key point provider for a patient on the list. Okay? So dialysis time, it used to be the time you were actually actively listed. So now what happens is if a person's not on dialysis, they have to get listed soon so that they can correct problems that might prevent their transplantation or slow their transplantation. They may get a perfectly matched kidney through the allocation system, but nonetheless, or they can get a living donor. So we can start evaluating living donors. So these are all important things for us to know and get early referrals of patients for transplantation. This just gives you a snapshot of our list. Again, I want to focus on the 2 on the left, diabetes mellitus. That's about 1/3 to 40% of our list right now is patients with diabetes, and hypertension makes up the rest. So if you can, a significant number of the other patients. So this is just hypertensive nephrosclerosis, which potentially could have been prevented with early diagnosis of hypertension and treatment. So this is a snapshot of our list. And again, by race, more than half of our patients are African American. Again, our urban setting plus the idea of hypertension. And then I guess one of the things I was going to close here is everyone's here because this is their passion, all right, to talk about and to make the best life for our patients with end-stage renal disease or chronic kidney disease. So I'm going to end with, every surgeon has to end with some pictures that are gory, but this is my passion, all right. This is a kidney that's gray and cold, and you're saying, I wouldn't want that, but yes, you would want that, because ultimately, this is what I call one of the miracles of medicine, because then ultimately, once we release the clamps, you can see how beautiful that kidney looks. It's red, it's pink, it's ready to make urine, and this is the miracle of transplantation that occurs every day in this country.